You know that feeling when you're faced with just a mountain of information, maybe for a big meeting, or you're exploring a new field, or even just plain curiosity, and you wish someone could just cut through all the noise and give you the absolute gold?
Yeah, like an express pass.
Exactly. Well, consider this your Express Pass today. We're doing a deep dive into something really profound: how cutting edge brain imaging is revolutionizing our understanding of mood disorders. Things like major depressive disorder, bipolar disorder.
And crucially, how it's shaping how we actually treat them.
Right. Because for so long, diagnosing and treating these conditions has relied, well, pretty heavily on subjective symptoms, hasn't it? Just how someone says they feel.
It has, and that leads to, significant variability in how people respond to therapies, lots of trial and error. Imagine trying to fix a really complex machine, like a high-tech engine, but without being able to actually see its inner workings.
That's a great analogy.
So our mission today, really, is to explore how scientists are now using these advanced tools to peer inside the living brain. The idea is to identify biological subtypes, you could call them, and work towards more objective measures.
And this isn't just lab bench science, right? This is about finding ways to personalize treatments,
Exactly.
to move beyond that frustrating trial and error and really bring those like aha moments right into mental health care.
That's the goal, because the challenge is huge. I mean, the individual suffering, the public health impact, the economic burden of mood disorders, it's immense.
Yeah.
And think about this. Over 50%, more than half, of patients with major depressive disorder don't actually achieve remission with their first treatment.
Wow, that's staggering. It really highlights the need for something better.
It really does.
Yeah.
So the shift we're seeing is towards thinking about these conditions not just as mental disorders, but truly as brain disorders.
Right. Looking for those objective biomarkers, things we can measure that go beyond just symptoms.
Precisely. And that's where frameworks like the National Institute of Mental Health's RDOC project the research domain criteria to come in.
RDOC, right, I've heard of that.
Yeah. Instead of just categories like depression, RDOC aims to understand dysfunction through basic science. It looks at fundamental dimensions, like how we process reward or react to threats, integrating behavioral, biological, environmental factors.
Which requires a ton of data, I imagine.
Massive amounts of data. And that's where brain imaging becomes absolutely critical. It helps us uncover the underlying mechanisms, the actual pathology in the brain.
Moving us towards, hopefully, more accurate diagnosis and, effective personalized treatments.
That's the promise, moving away from guesswork towards biologically informed care.
So let's unpack that. Using these powerful new tools, what are we actually seeing? What's imaging revealing about the origins, the etiology and pathophysiology of these disorders? Maybe start with genetics.
Sure, genetics is a big piece of the puzzle. We know mood disorders are multifactorial. It's not one gene. It's a complex interplay of many genes, polygenic, plus environmental factors.
And the heritability, how much genes contribute, it varies quite a bit, doesn't it?
It does, and the numbers are pretty striking. For major depressive disorder, MDD, the estimate is around 37%. But for bipolar disorder, it leaps up to about 85%.
85%, wow.
Yeah, and schizophrenia is similar, around 83%. What's really exciting now is the progress in identifying specific genes. We're seeing shared genetic links, for instance, between bipolar us and schizophrenia, and also between bipolar 2 and MDD.
Interesting.
And for bipolar specifically, large-scale genetic studies, GWAS studies, are pinpointing specific biological pathways involved things like glutamate signaling, calcium channels, second messenger systems, even hormonal regulation. Imaging helps us see how these genetic factors might play out in brain structure and function.
Okay, so it's not just the genes themselves, but how they manifest in the brain. Imaging is showing actual physical differences, right? Anatomical, functional, chemical abnormalities.
Exactly. In key brain regions and circuits involved in mood regulation, we consistently see changes in areas like the prefrontal cortex, specifically parts like the orbitofrontal, anterior cingulate, dorsomedial, and ventromedial areas.
The brain's executive control centers, kind of?
Sort of, yeah.
Yeah.
Involved in decision-making, regulating emotions. And then there's the limbic regions, the amygdala, the hippocampus, which are more like the emotional core, crucial for fear, memory, processing, emotional stuff. Plus other areas like the thalamus, hypothalamus, the insula, temporal lobes. These are involved in instinctual behaviors, keeping the body in balance, processing emotions.
So it sounds like a whole network of areas.
It really is. And the
Yeah.
critical thing isn't just the individual areas, but the interactions between them,
Hmm.
especially how those deeper subcortical regions connect with the neocortical associative areas.
Right.
That interaction is what allows for emotional regulation, helps us navigate social situations, integrate our feelings with our thoughts. It's the whole circuit.
That makes sense. Okay, what about stress and reward? These seem absolutely central to mood disorders. We know stress responses can go haywire, especially in young people with BD or MDD.
Yeah, the normal acute stress response is adaptive, helps us cope. But in mood disorders, these pathways can become dysregulated. It can lead to maladaptive behaviors. And increasingly, we're conceptualizing mood disorders as involving aberrant responses to reward or goal-directed stimuli,
Exactly.
especially if there's been early trauma.
And imaging lets us see that happening in specific reward circuits.
Yes, we can look at regions like the striatum, which includes the nucleus accumbens, the putamen, the caudate, and also the orbitofrontal cortex. These are key hubs for processing reward and motivation.
And are there differences between, say, bipolar and MDD in how these areas respond?
Definitely. Think of it like this. In bipolar disorder, particularly during mania, the reward system can seem hyperactive. We see increased striatal volume sometimes, hyperactivity in these regions. It can relate to that feeling of hyperodonia, like
Yeah.
everything is intensely pleasurable.
Okay.
But in major depressive disorder, it's often the opposite, a blunted response. We see reduced striatal activation when anticipating rewards, sometimes reduced overall striatal volume, less activity when actually receiving a reward. It's like the system's turned way down.
Like that inability to feel pleasure and hedonia.
Exactly. And another really interesting finding, especially in youth with MDD, is reduced hippocampal volume. We
Yeah.
can even detect this as early as preschool.
Preschool.
Yeah. It raises questions, is it a pre-existing risk factor or maybe a consequence of early stress that leads to this blunted emotion processing? It's a key area of research.
Okay, so we've talked structure, function, and reward. What about the brain's chemistry? Neurotransmitters like glutamate, GABA, dopamine. And what about neuroinflammation?
Right? Chemistry is crucial. There's converging evidence now for altered levels of glutamate, the main excitatory neurotransmitter, and GABA, the main
Yeah.
inhibitory one.
Brains go and stop signals.
Kind of, yeah. In MDD specifically, we see signs of GABergic abnormalities,
Hmm.
issues with the stop signal, and also reduced GALX, which is a combined measure of glutamate and glutamine in the anterior cingulate cortex, a key emotion regulation area. So imbalances there seem important.
What about dopamine? That always comes up with pleasure and motivation.
It does, and dopamine likely plays a role, especially maybe in the fluctuating states of bipolar disorder.
Yeah.
But honestly, the molecular imaging literature specifically on dopamine and bipolar disorder is still pretty sparse.
Really?
Yeah, many studies are underpowered, findings are conflicting. It's hard to draw really solid conclusions yet. We need more robust research there.
Okay, that's surprising. What about neuroinflammation then? That seems to be a really hot topic.
It is, and for good reason. One of the most highly replicated findings, particularly in MDD, is elevated TSPO binding. Yeah, it's a protein marker, and elevated binding is best explained by microglial activation. Microglia are the brain's resident immune cells.
So inflammation in the brain.
Essentially, yes. And what's really significant is that greater TSPO binding often correlates with how long someone's illness has gone untreated. This points towards something called neuroprogression.
Meaning the illness itself might be driving ongoing inflammation.
That's the hypothesis. It suggests the longer the illness goes on, the more these inflammatory changes might accumulate. But, important caveat, studies using TSPO imaging specifically in bipolar disorder or dysthymia are still lacking, so more work needed there too.
Got it. So much complexity. Okay, let's shift gears slightly. How are scientists actually doing all this? What's in the imaging toolkit? Let's start with structural MRI. What's its main strength?
Structural MRI, or SMRI, its superpower is providing incredibly detailed anatomical maps of the brain. It's non-invasive, uses magnetic fields, and gives us unmatched detail on brain structure.
So you can see changes in volume, gray matter, white matter.
It's exactly gray matter, white matter, overall volume, surface area, even the thickness of the cortex. And in MDD, we consistently see those volumetric reductions we talked about, particularly in prefrontal areas like the orbitofrontal cortex and anterior cingulate, and limbic regions like the amygdala and hippocampus.
And you mentioned MDD is more about regional changes, whereas bipolar might show more global changes.
Broadly speaking, yes. While MDD can have some global changes, it's often characterized more by these specific regional morphometric differences. In bipolar disorder, we sometimes see more general brain volumetric reduction, but also specific changes like enlargement of the lateral ventricles
Right.
and gray matter deficits in
Yeah.
areas like the thalamus, hippocampus, amygdala, insula, ACC, and prefrontal cortex. Plus, evidence of reduced white matter volume and disrupted white matter integrity problems with the brain's wiring.
It's fascinating how you can compare across disorders too, like the hippocampus volume you mentioned earlier.
Right. All three MDD, bipolar, and schizophrenia tend to show reduced hippocampus volume compared to healthy controls. But the degree often differs. It tends to be greatest in schizophrenia, smallest in MDD, where it seems driven more by recurrent episodes, and bipolar is somewhere in between. Highlights both shared vulnerabilities and distinct patterns.
Super interesting. Okay, from structure to function, what about functional MRI, fMRI? How does that show the brain in action?
So if SMRI gives you the map, fMRI shows you the traffic flow. It detects tiny changes in blood oxygenation levels, the BOL-D signal, blood oxygen level dependent signal. Basically, where the brain is more active, it needs more oxygenated blood.
You're right.
So fMRI lets us study functional brain activity, especially how different brain networks communicate and operate. We often talk about three major ones: the default mode network, or DMN.
That's the mind-wandering network, right?
Yeah, active during rest, self-referential thought. Then the salience network, SN, which detects important or salient stimuli, things that grab your attention. And the central executive network, CEN, which is engaged during tasks requiring focus and cognitive control.
And how are these networks disrupted in mood disorders based on fMRI?
We see some consistent patterns, especially in MDD. There's often increased connectivity within the anterior part of the DMN. It's like that self-focused ruminative part of the brain is sort of stuck in overdrive.
Makes sense.
We also see increased connectivity between the salience network and that anterior DMN. And importantly, decreased connectivity between the posterior DMN and the central executive network.
What does that mean functionally?
Well, the salience network is thought to play a key role in switching between the internally focused DMN and the externally focused CEN. So if the SN isn't working right, or its connections are altered, it might lead to problems disengaging from that internal rumination, DMN, and engaging with tasks or the outside world, CEN.
That really paints a picture of getting stuck internally.
Exactly. And fMRI is also used in those reward studies we discussed, showing the blunted striatal activation in MDD versus the increased ventral striatum and medial OFC activation often seen in bipolar mania.
Okay, next tool. Magnetic resonance spectroscopy, MRS. This sounds like it gets into the actual chemistry.
It does. MRS gives us an unprecedented window into the in vivo neurochemistry of the brain, non-invasively. It measures the concentration of various key metabolites, the chemical byproducts of brain activity.
Like what sort of metabolites?
Things like N-acetylaspartate, or NLAA, which is often seen as a marker of neuronal health or integrity. Total creatine and phosphocreatine, which relate to energy metabolism, and crucially, glutamate, GLU, and GABA, those key excitatory and inhibitory neurotransmitters.
So what has MRS found?
Some examples. Studies have found reduced NLA in some brain regions in bipolar disorder, potentially suggesting neuronal dysfunction. We talk about the finding of decreased GLS glutamate plus glutamine in the anterior cingulate cortex in MDD.
All right, the excitatory imbalance.
Exactly. And in bipolar, there are findings related to phosphocreatine levels, even dynamic abnormalities in how it's synthesized, which interestingly, lithium treatment might actually improve. So it gives us a chemical target potentially related to treatment response.
Very cool. Okay, positron emission tomography, PET. This one uses radio tracers, right? To see molecular targets.
That's right. PET is a 3D nuclear medicine technique. You introduce tiny amounts of a radioactive tracer designed to bind to a specific biological target in the brain, like a receptor, a transporter protein, or an enzyme.
So you can see exactly where, say, serotonin transporters are or dopamine receptors.
Precisely. It's incredibly valuable for drug discovery, for confirming that a potential antidepressant is actually hitting its target in the human brain. And as we mentioned, it's key for imaging neuroinflammation via TSPO binding.
Got it. But you also mentioned the dopamine findings in bipolar using PE were still a bit unclear.
Yeah, unfortunately for the dopamine system, specifically in bipolar disorder, the PET literature is still quite sparse, and the findings have been inconsistent. It just highlights the challenges and the need for more research to clarify dopamine's precise role using these techniques.
Okay. Now for something different. Magnetoencephalography, MEG. This measures the brain's magnetic fields.
Correct. MEG is fascinating because it provides a very direct measurement of neural electrical activity. While fMRI measures blood flow, which is an indirect correlate, MEG picks up the extremely weak magnetic fields produced by the brain's electrical currents.
And it has really good timing, right? Temporal resolution.
Excellent temporal resolution, down to milliseconds. This really complements fMRI, which is better at where activity is happening. MEG tells you when it's happening with great precision. It uses highly sensitive detectors called squeeds. And despite what some think, it's not insensitive to deep brain sources.
So what kind of things has Meg shown in mood disorders?
A few examples. Looking at somatosensory evoked fields, the brain's response to touch MEG has shown reduced excitability in MDD. Interestingly, with ketamine treatment, responders show an increased evoked gamma band response.
Gamma waves, the fast ones.
Yeah, hinting at a potential mechanism for ketamine's rapid effects. When looking at responses to emotional pictures, MEG studies in MDD have found attenuated visual evoked fields and also a kind of neural bias towards negative stimuli. The brain seems more tuned to the bad stuff. In cognitive tasks like spatial navigation, reduced theta activity in the hippocampus has been seen in MDD. And even just resting state MEG shows differences like elevated slow-wave delta activity in MDD and reduced theta in frontal areas. Lots of potential biomarkers there.
Okay, now for near-infrared spectroscopy, NIRS. You said this one's more portable.
Yes, NRS is non-invasive, relatively inexpensive, and portable. You can use it while someone is sitting comfortably, maybe even in a clinic setting. It works by shining near-infrared light into the scalp and measuring how much is absorbed or scattered back.
And that tells you about brain activity.
Indirectly. It measures relative changes in the concentration of oxygenated hemoglobin, oxy-HB, and deoxygenated hemoglobin, deoxy-HB, in the cortex. Similar in principle to fMRI's bold E signal, but using light instead of magnets.
Are there limitations?
Definitely. The main one is depth penetration. PRS can really only measure activity in the outer layers of the cortex, like the dorsolateral prefrontal area. It can't easily get signals from deep structures like the cingulate, amygdala, hippocampus, or subcortical regions, and its spatial resolution isn't as good as fMRI.
But still useful for some things.
Absolutely. Despite limitations, it's shown promise for helping to distinguish between psychiatric diagnoses. For example, using tests like verbal fluency, NIRS patterns have achieved pretty decent classification accuracy, up to around 85% for non-MDD diagnoses and maybe 75% for MDD in some studies. Not definitive, but potentially a helpful clinical aid.
Okay, and finally the classic. Electroencephalography, EEG, and its cousin, event-related potentials, ERPs. Still valuable tools.
Hugely valuable. EEG is cost-effective, has fantastic temporal resolution like MEG. It measures electrical activity directly. ERPs are derived from EEG. They're the average brain response time lock to a specific event or stimulus.
So you can see the brain reacting millisecond by millisecond.
Exactly. ERPs let you dissect cognitive processes. Early components like the N1 or P100 reflect initial sensory processing, while later components reflect higher-order cognitive operations. The amplitude tells you something about the strength of the neural response.
And you mentioned one specific ERP, the LDAEP, as a potential marker for treatment response.
Yes, the loudness dependence of auditory evoked potentials, or LDAEP, derived from the N1P2 complex. It's thought to reflect central serotonergic activity, so there was hope it could predict antidepressant response.
But the results have been mixed.
Very mixed, unfortunately. Some studies find increased amplitude correlates with severity or suicidality. Others find negative correlations. Others, no difference at all. It really underscores the complexity and heterogeneity of depression. It's not one single thing.
Yeah, that seems to be a recurring theme. Now, within EEG, there's quantitative EEG, analyzing those brainwave patterns, alpha, theta, gamma. What are the key findings there, especially with alpha?
Alpha activity is interesting. A fairly well-replicated finding in MDD is elevated alpha power at rest, especially in parieto-occipital regions, sometimes frontal too. It often correlates with depression severity.
And then there's frontal alpha asymmetry, FAA. That's been talked about a lot.
It has. The idea was decreased alpha power on the right side compared to the left in MDD, supposedly reflecting a hyperactive right prefrontal cortex linked to withdrawal, negative emotion, and a hypoactive left prefrontal cortex linked to approach, positive emotion.
A neat theory, but...
Here's where it gets really interesting, or maybe frustrating for researchers. Despite being such a well-known concept, many studies, including some very large ones, have actually failed to reliably replicate the FAA findings in MDD.
Really? So it might not be as solid as we thought.
It seems that way. It highlights how sensitive these measures can be to technical differences, different patient groups. We really need large-scale meta-analyses to sort it out. It's a good reminder that appealing ideas need rigorous, consistent evidence.
Absolutely. What about other brainwaves like theta and gamma?
Theta activity, especially frontal midline theta, has been implicated in altered emotional regulation. Interestingly, the hippocampus is a major generator of these frontal theta waves. So disruptions there could link memory and emotion problems.
And gamma.
The fast waves. Gamma activity correlates with things like focused attention, memory formation, perception, higher level processing. It's being explored as a potential novel biomarker for MDD. Findings are a bit mixed, sometimes elevated, sometimes reduced, depending on the task, but it has shown some ability to differentiate unipolar from bipolar depression.
Could gamma even predict treatment response?
That's a really exciting possibility. Animal studies show that SSRIs and noradrenergic drugs can have opposing effects on gamma power. So, maybe one day gamma patterns could help guide which type of antidepressant might work best for an individual.
Personalized medicine based on brainwaves?
Potentially.
Mm-hmm.
And look at ketamine. Its rapid effects are associated with increased gamma power. It might follow an inverted U curve where optimal gamma is linked to stable mood, euthymia. Even non-drug treatments like TMS seem to increase gamma signaling after recovery. So gamma might be a common pathway for improvement.
This is incredible, connecting the imaging tools directly to treatment possibilities. Let's talk more about that. Lithium for bipolar disorder. Imaging is showing more than just symptom control, right? It seems to actually change the brain.
Yes, this is one of the most fascinating areas. We know bipolar disorder is associated with subtle structural brain changes. But large imaging studies are showing that lithium's treatment is associated with an attenuation or even reversal of some of these changes.
Like reversing volume loss.
Exactly. Attenuating subcortical volume deficits in the amygdala, putamen, globus pallidus, for example, and apparently reversing some cortical thinning, like in prefrontal and parietal regions.
Wow. So it might be neuroprotective or even promote growth.
That's the implication. It strongly suggests a mechanism beyond just symptom management, potentially related to promoting brain health, maybe even neurogenesis. And there's a potential link to BDNF, brain-derived neurotrophic factor.
The brain's fertilizer.
Kind of. There's evidence emerging for a relationship between lithium treatment, increases in hippocampus volume specifically in a subregion called the dentate gyrus, which is important for neurogenesis, and changes in BDNF levels measured in the blood serum.
So BDNF levels in blood could predict lithium response.
If confirmed, yes. It could become an accessible early biomarker. Needs more research, but very promising.
What about standard antidepressants? How is imaging helping us understand how they work or who they work for?
Well, any effective treatment has to modify the underlying dysfunction we see with imaging. DTI studies, looking at white matter tracks, suggest that the integrity of pathways connecting areas like the ACC, the DLPFC, and the hippocampus is important for antidepressant response and predicting remission.
So the wiring matters for treatment success.
It seems so.
Yes,
And
sir.
PET data offers another angle. It suggests that pretreatment levels of certain targets, like the 5-HT1A serotonin receptor or the serotonin transporter 5-HTT, might predict response better than just looking at how much the drug occupies those targets over time.
Predictive, not just reactive.
Exactly. It opens the door to potentially selecting treatments based on a baseline scan. And interestingly, some research also hints that social interactions might be necessary for the full clinical response to medication, suggesting psychological factors can really enhance pharmacology.
Which leads perfectly into psychotherapy. Can imaging show us how talk therapies like CBT, BAT, IPT actually change the brain?
Absolutely. This is incredibly validating for psychotherapy. It's not just talking. It's inducing measurable biological changes. We see impacts on brain function, metabolism, even structure.
So what kinds of changes? What does CBT do in the brain, for instance?
CBT is associated with changes like reduced activation in the medial prefrontal cortex and ventral ACC when people evaluate negative things. So less reactivity to negativity,
Okay.
and conversely, increased activation in those same regions when responding to positive stimuli, helping people engage with the positive. It also seems to increase activation in areas like the amygdala, caudate nucleus, and hippocampus, maybe recalibrating those core emotional circuits.
And there was that finding about connectivity changing, too.
Yes, a really interesting one. Improvement with CBT seems to correlate with a reduction in overly strong frontal-cingulate connectivity that was present before treatment. It's like the therapy helps loosen up rigid negative thought loops at a neural level.
Fascinating. What about other therapies like behavioral activation?
Behavioral activation therapy, or BAT, which focuses on increasing engagement in rewarding activities, has been linked to decreased activation in prefrontal, cingulate, and cerebellar regions when people respond to sad stimuli. Again, suggesting a shift away from processing negativity.
So these therapies are actively remodeling brain function.
The evidence strongly suggests functional improvement and points towards the neural mechanisms underlying their success. But again, it's important to acknowledge variations. Findings depend on the specific method, and sample sizes are often small, so we need more large, well-designed trials.
Understood. All this data, though, structural scans, functional scans, chemistry, electrical activity, it's a massive amount of information from each person. This sounds like a job for machine learning, right?
You've hit the nail on the head. Traditional statistics really struggle with the sheer volume and high dimensionality of modern neuroimaging data. Machine learning algorithms are much better suited because they can learn complex patterns from these huge data sets and make predictions on new data.
They can see patterns we might miss.
Exactly. They can integrate information across different imaging types across many brain regions to find subtle signatures associated with diagnosis, symptoms, or treatment response.
So what are the main ways ML is being applied here?
Several key applications are emerging. One is diagnostic classification. Using neuroimaging data, ML models can differentiate patients with mood disorders from healthy controls with pretty good accuracy. And importantly, they're showing promise in distinguishing between different disorders, like bipolar versus MDD, which can be clinically difficult.
Okay, distinguishing diagnoses. What else?
Decoding clinical variables. ML can learn the relationship between brain scans and clinical scores, like a depression rating scale score. It can predict the score from the scan and tell us which brain features are most predictive.
Linking brain patterns directly to symptom severity.
Right. And perhaps most excitingly, identifying disease subtypes. ML is crucial for moving beyond broad labels like depression and identifying biologically distinct subgroups or biotypes within those labels. People whose depression might have different underlying neural mechanisms.
Which is the key to personalized treatment.
Precisely. If we can identify these biotypes, we can potentially match them to the treatments most likely to work for their specific brain profile. And finally, ML helps with mechanistic understanding. By finding these predictive brain markers, it helps us zero in on the core pathophysiology.
So the ultimate aim really is personalized treatment based on an individual's neural signature.
That seems to be the most promising path forward. Moving away from one-size-fits-all towards treatments tailored to the individual's brain biology, that's how we can really improve outcomes and reduce the trial and error burden.
So we've covered a huge amount of ground here. We've dived deep into this incredible world of brain imaging, seeing how it's truly unlocking the mysteries of mood disorders.
Yeah, from genetics to those intricate brain networks, the effects of medications like lithium, even the changes from psychotherapy, we're visualizing the brain in ways that just weren't possible before.
And just to reiterate, this isn't just, cool science on a computer screen. This points towards a future where your unique brain signature could guide a much more precise, much more effective approach to your mental health. Less guesswork.
Absolutely. Making mental health care potentially as targeted and personalized as treatment for heart disease or cancer.
So here's a final thought to leave you with. Imagine a world, maybe not too far off, where a brain scan could tell us not just if you have a mood disorder, but what kind it is biologically and which specific treatment, medication, therapy, maybe even a specific lifestyle change is most likely to work best for you, for your unique brain. How might that fundamentally change everything about how we experience and manage mental health care, making it truly personalized brain health optimization?